Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association EHA. My name is Isabel Olivera and I'm a medical writer for the EHA. I have the pleasure to have here with me today Professor Domenico Girelli. Welcome, Professor Girelli. Can you please introduce yourself?
I am Domenico Girelli. I am Professor of Internal Medicine at the University of Verona with a long-standing experience in iron metabolism, and I am a clinician. I am especially involved in the care of patients with disorder of iron metabolism, either iron deficiency or iron overload.
So we are going to discuss today the regulation of iron metabolism in polycythemia vera, and especially the role of Hepcidin Mimetics in the regulation of hematocrit in these patients. Could you start by giving us just a brief overview of what polycythemia vera is and what its specific impact is on hematocrit levels?
Yes, polycythemia vera is a myeloproliferative neoplasm that is characterized by uncontrolled increase of erythrocytes and uncontrolled erythropoiesis, and it leads to a number of complications, including thrombosis, including high hematocrit, and so on. And in this setting, it is very important to know that there is the arrangement of iron metabolism, because iron, of course, is required for erythropoiesis, and in a condition in which erythropoiesis is clearly increased, pathologically increased, like polycythemia vera, there is a huge risk of developing iron deficiency because of the need of iron in order to fuel the increased erythropoiesis. So in this way, it has been recently demonstrated that more than one half of patients with PV actually have iron deficiency at the diagnosis, and this iron deficiency can also be influenced by therapeutic phlebotomies that are the first-line treatment of PV, of course, and for this reason, iron deficiency develop in the vast majority of patients with PV, either at a diagnosis or during the therapeutic phlebotomies. And in this sense, it is important to note that hepcidin, which is the master regulator of iron metabolism, systemic iron homeostasis, by inhibiting ferroportin, and thus by inhibiting the iron entry into the plasma, hepcidin is suppressed in patients with polycythemia vera, and there are new data and a number of papers that has recently published that suggest either in animal models of PV or in humans, patients with PV, that increasing hepcidin, or increasing by mimicking, for example, the action of hepcidin, is may ameliorate the PV phenotype, and particularly may help in reducing the need of phlebotomies in these patients.
So Hepcidin Mimetics can regulate iron metabolism, and this can have an effect on PV. So what are the agents that are being studied now as Hepcidin Mimetics for the use on the regulation of iron metabolism in PV?
Yes, for the moment, the most used compound is Rusfertide, that is a small molecule that need subcutaneous administration weekly, and it is able to block ferroportin like hepcidin. And this has been studied in phase 1, phase 2, and now there is a phase 3 trial ongoing in patients with PV. And also it has been used also in animal models, and it is very effective in mimicking the action of hepcidin. But there are some other approaches that are ongoing. The most promising one, to my view at least, is the use of RNA silencing approach that are targeting TMPRSS6. TMPRSS6 is a membrane proteases that is an upstream inhibitor of hepcidin. So by silencing TMPRSS6, you can increase the level of hepcidin. And this has been used by the group of Bennett and co-authors, the Australian co-authors, that published a very interesting paper on blood early this year in a mouse model of Polycythemia Vera. And they demonstrated that by silencing the TMPRSS6 and increasing hepcidin, this resulted in a significant amelioration of the PV phenotype of the mouse. So this is an encouraging option, because it seems that it is likely devoid of possible side effect, because the target is very unique, and also it would require just one single administration subcutaneous that should last at least 3 weeks or 4 weeks. So it could be an attracting option for patients, especially considering that the objective of such therapies is to control the hematocrit without the need of maintenance phlebotomies. And this may be important also in theory, because we know that when we treat such PV patients with phlebotomies, we have oscillation of hematocrit, but in this case, the hematocrit is maintained relatively stable in this patient without increase and decrease according to the time of phlebotomies. So this could be an attractive option in the near future for these patients.
So it is possible that with the treatment with Rusfertide, the PV patients will be free from phlebotomies?
Yes. It has been already demonstrated that the vast majority.
Completely
yes.
Okay.
The question is whether or not these could be useful in preventing the thrombotic complications. In theory, it should be, of course, but it needs to be demonstrated for the moment. And we, for the moment, just have data that suggests that a consistent number of patients treated with Rusfertide are able to avoid maintenance phlebotomy.
So will this make the treatment of PV dependent only on Rusfertide, or these patients will have to have other kinds of drugs at the same time?
It depends on the severity of the disease. Maybe that Rusfertide could be considered like a single agent in patients with mild phenotype, of course, but it is anticipated that in patients with more severe phenotype, we should use more than a single approach.
At the moment, Rusfertide is still in clinical phase 3, in clinical trials in phase 3, so it's not yet approved. What are the perspectives? When will it be available?
Okay, I don't know exactly because maybe in the next year, maybe, but it depends on the regulatory agency, of course. The data are convincing, but we have also to consider that there are some safety signals about, for example, transient increase in the platelet count in patients treated with Rusfertide, but it seems like a transient effect. So the clinical meaning is uncertain for the moment, but likely should not be important. And from the other side, no other main side effect have been described for the moment. And of course, we are waiting for the results of the ongoing clinical trials.
Are there other avenues of research to treat polycythemia vera, and especially the regulation of iron metabolism in polycythemia vera?
Since the discovery of hepcidin and the hepcidin-Ferroportin axis, it became evident that targeting these axes could be a good therapeutic option in a number of different disorders. So in this field, we have a number of compounds in the pipelines of different companies, either hepcidin antagonists or hepcidin agonists. So Rusfertide is a first-in-class, but there are many other agents that are on the pipelines that could be useful in the near future.
There are other diseases that affect iron metabolism, many diseases such as hemochromatosis, and so all of these are also being treated with these hepcidin mimetic agents.
In principle, for example, hemochromatosis could be the ideal condition to be treated with an hepcidin mimetic, because hemochromatosis is due to hepcidin deficiency, genetically determined iron deficiency. The point is that we have to clearly show the advantage of this treatment over the classical treatment, that is phlebotomies that are simple, efficient, and well tolerated in general. So there are some patients with hemochromatosis that are unable to well tolerate phlebotomies, because phlebotomies need to be done in the hospital, especially for patients that live a long way from the hospital. This could be a problem. There are some patients with hemochromatosis that need phlebotomies, and they are unable to tolerate them. So hepcidin agonists could be an option. There are some clinical trials also in this direction. But of course, we have to demonstrate that the new drug is superior, or at least non-inferior, to the classical treatment.
What do you find most fascinating about these new developments in the regulation of iron metabolism?
Now, to my view, it is. I was fascinated by the fact that iron metabolism in PV was nearly neglected until a few years ago. And another point that is important is that by using hepcidin mimetic, you not only observe a reduction of the need of phlebotomies, but also the patients have an increased well-being because they suffer from iron deficiency, and iron deficiency, of course, they do not have anemia like the classical condition of iron deficiency, but iron deficiency per se is an health problem that can affect, for example, the muscular tone, fatigue, and many other conditions that are related to iron deficiency. It seems from the preliminary data that patients treated with this compound have a low burden of symptoms related to iron deficiency.
So it will be a great advantage to be free of phlebotomy and then improved
yes, in
prevent iron deficiency because of phlebotomies.
This
is
the rationale for treatment. But we are still in the first part of the story, of course, but we urgently await for the second part of the story, but the results are very promising, at least in my opinion.
So if you were to summarize what the state of this research and the translation to the clinical setting is at the moment for a general hematologist, what would be your takeaway message?
My takeaway message is to be aware of the problem of iron deficiency in these patients, and to be alert in order to find this new possibility as soon it will be available, especially in some categories of patients with PV that could benefit with such new treatment. That if the safety data are confirmed, of course, and especially for patients that are not good candidates for maintenance phlebotomies because they live away from the hospital and so
on. Is there anything else that you would like to add for our audience?
I think that the modulation of the Hepcidin-Ferroportin axis is a very promising tool in many fields of hematology, not only in PV, as I mentioned before, but in a number of disorders characterized by iron overload. For example, iron-loading anemias are also good candidates for modulation of hepcidin, and maybe also in some other conditions that are relatively frequent in the hematology practice.
Thank you for this very enlightening discussion. Thank you, Professor Girelli, for sharing your expertise with us, and to all of you for listening.